Healthy Women launched WomenTalk as part of our live webinar series to bring together healthcare professionals and women to connect about their health. Now more than ever, we know how important it is to take care of our health and how impactful it is to share our health journeys. We are proud to present current and up-to-date information brought directly to you from guests who are top healthcare providers, researchers, experts, and leading professionals in their fields. At Healthy Women, we bring you authentic, engaging, and personal stories by women for women. Join the conversation today by asking questions live in the comments section. Thanks for joining us today.
Founded in 1988, Healthy Women is the nation's leading independent nonprofit health information source for women. Our mission is to educate and inspire women age 35 plus to make informed health choices for themselves and for their families. Our website provides objective, research-based health information reviewed by medical experts. And for more than 30 years, millions of women, healthcare professionals, nonprofit and corporate partners, and the media have come to us for answers. To learn more, visit healthywomen.org.
Hello, everyone. On today's episode of Women Talk, we are going to be talking with health professionals to better understand the complex disease of obesity. There's no one-size-fits-all solution to obesity. Healthy eating and physical activity alone may not work for everyone. Obesity can require medical management, yet only 55% of people with obesity receive a formal diagnosis, and even fewer receive long-term obesity care. A supportive healthcare professional is key to a woman feeling comfortable listening and participating in the conversation and beginning their journey to better health. And the importance of understanding your patient's culture and infusing that into their overall care plan is so important. And we're going to hear much more about that in just a bit. To discuss this important topic, I am so pleased to welcome Dr. Veronica Vitale from the National Association of Hispanic Nurses. Dr. Veronica Vitale from the National Association of Hispanic Nurses, and Dr. Loretta Lee from the National Association of Black Nurses, and Dr. Kaylin Oristal from the Haitian American Nurses Association. Welcome, ladies, and we are going to dive right in. So question number one, and this is for all of you, but I'm going to have Kaylin, Dr. Oristal, I'm going to have you kick us off. Are healthcare professionals having a conversation with women about obesity? And if not, why?
Good afternoon, everyone. I'm just really excited to be here, and wonderful, wonderful question. So as a healthcare provider myself and a faculty who teaches nursing and nursing science, the conversations are lacking. It takes an intentional effort to have that conversation, and it is that motivation and intent that inspires the conversation and being comfortable with your client. Actually, some nursing 101 is establishing that therapeutic relationship so that you can bridge these conversations. They're difficult ones.
They are difficult. And Drs. Vitale and Dr. Lee, what are you seeing as far as in your, as heading up some great organizations and working under the Alliance of Obesity? What are you seeing in regards to the evolving the conversation and the educational tools that so many nurses need in order to successfully manage their patients?
Thank you, Beth. I guess I'll go next.
Sure.
So I guess it depends on, to go back to the question that you originally posed, I guess it depends on your healthcare provider. I think most healthcare providers, at least in my area, they do have somewhat of a conversation with their patients related to obesity, but it's in the context of talking about chronic disease. So, in order to make nurses, in order to make other providers comfortable with having those conversations, we need to have specific educational material that is dedicated to talking about obesity as a chronic disease, obesity as an epidemic, and not obesity as a lifestyle choice, or a poor diet and exercise.
And Dr. Vitale, do you have anything to add to this?
So, well, thank you. It's an honor to be here for this important discussion. The National Association of Hispanic Nurses is committed to advancing health equity and addressing health disparities. And NAN is a collaborating organizational member of the Nurses Obesity Network, which is dedicated to increasing awareness and education regarding obesity. And then we, NAN, advocates for our marginalized communities and dedicated to ensuring obesity educational information is culturally relevant and available in Spanish as well. So as my colleague said, it's important for the educational materials to be relevant for our communities. I did want to share a few statistics regarding obesity and Hispanics. Approximately 78.8% Hispanic women are overweight or obese, compared to 64% of non-Hispanic white women. And Hispanics are 1.2 times more likely to be obese than non-Hispanic whites. And then also access to care is also really challenging for many Latinos, as many Latinos are not insured or are uninsured. Are uninsured or underinsured, so they tend to not go to the doctor. So this is a challenge for us with Latinos. So again, NAN is really committed to making sure that the care for obesity is relevant for our communities and it's culturally competent. That our healthcare providers are culturally competent as well when providing care for our communities.
I think that's so important, and it's so great that all three of your organizations are kind of paving the path forward. And I know, do all of you belong to the Obesity Alliance? I know Drs. Vitale and Dr. Lee, you both your organization, and Dr. Orestal, your organization belongs to the Obesity Alliance as well. Why is that important? Can you share a little bit about the Alliance?
So I am the co-chair for the Nurses Obesity Network. This network is extremely important. It consists of a diverse group of national nursing organizations, and our primary goal is to change the way people view, treat, and advance the care of obesity. We use ourselves as an example. So many of us as nurses struggle with obesity.
True.
So we approach things from the perspective of, we provide education that providers can use to help them take care of their patients, but we also use ourselves as a model, because just because you're in healthcare, it does not mean that you do not have a struggle with obesity. So we're very proud of the work that we're doing. We have several organizations, as you mentioned, Gerontological Society of America, the Hispanic Nurses Association, and other nursing associations who have decided that collectively our voices matter in taking a new stance or directing the way we view the obesity epidemic.
I love it. It's so much more powerful when we all work together, isn't it? And then under one umbrella, that's the way that we're going to evolve, and that's how we're going to change. So I love hearing the background on this, and I love the fact that all three of your organizations are working under the Alliance for Obesity. That's amazing. I'm going to jump to our second question, and Dr. Orestel, this is for you. Can you share the success and how you're managing not just the conversation on obesity, but more importantly, the continuum of care for obesity? And part two is, what is part of that care plan? Is it just eating, activity, mental health, medication, surgical options? Can you explain a little bit more? So the first part of the question again is, share the success and how you are managing not just the conversation of obesity, but more importantly, the continuum of care today.
It's about, as I mentioned earlier, really making an intentional effort to have the conversation outside of, if you're overweight or obese, you're more at risk for hypertension or diabetes. The Black and brown folks, they already know that. It's all over, it's everywhere. And access is an issue to all minority groups. And it's about, again, having that conversation intentionally, looking at the big picture, taking into consideration that someone's culture really impacts their roadmap as it relates to how they look on the inside and the outside. Your overweight client, my overweight clients, they know they're overweight. They don't need me to tell them that, but they need me to help them manage that chronic illness. And it is a chronic illness, which sometimes requires a collaborative approach. So someone may hear Dr. Orestel. I am not a medical doctor. I am an advanced practice nurse, a nurse with advanced training. So I have I have a wonderful scope and great autonomy, but at the same time, I know that I must tie in key players as part of the interdisciplinary care team, right? So it means referring, knowing when to refer, knowing when you can manage someone, right? And there's some taboos, especially in my culture. Weight, if you're Haitian, the robustness, and I think this is something that's even plugged into our ethnic identity as Africans and African Americans. When you see someone who is robust and big, obese, it symbolizes stature. I know in Haiti it does. The bigger the belly, the more well-to-do the person is. So it's breaking those misconceptions, right? So the bigger the waist circumference, the higher your risk for having a heart attack, developing diabetes. And you have to know when exercise and diet are not enough, right? So I may have, and this happens all the time, and it happened to me personally, my wake-up call, when I went to the doctor and the doctor says, hey, your A1C is 8.5. Like, you got to lose some weight. And as soon as I heard that, he spoke to me on a higher level. I would tell my clients, like, look, you may have diabetes. A tear came down, my face.
Sure.
And I spent a whole month working to get that A1C down. And intentionally, it did go down, but for a moment, because 6 months later, I was right back at it. I had put the 13 pounds back on. I heard medication. I didn't want to go there. But sometimes that's where you need to go when diet and exercise. I don't want to say fail, not enough.
Not enough.
Yeah, and
it's so important. And share. Do you mind sharing? Because it was so great meeting you yesterday, and you shared a little bit about your personal story. What are some of the things that you incorporated into your daily routine that helped you?
Oh my goodness. I have made looking at what I eat a cornerstone. I mean, it's almost I tend to count calories, which doesn't work well for those my it doesn't work well for my clients because they don't understand the concept, especially someone who's Haitian. You're trying to get them to lose weight. They don't understand that. But I use things like my plate and I show them, like, look at this plate. Typically, Caribbeans don't eat a half a cup of rice. They eat 6 cups, right?
Okay.
6 cups
It's
of
the
rice.
portion.
And then now this brown rice, they think, oh, it's healthier. So why not just have 6 cups of
Right.
brown rice or 6 cups of blé? Blé is bulgur wheat. It'll have you going to the bathroom. However, it's still way too much.
Too much. Yeah.
And it's about, for me, the wake up call, knowing that my parents both are diabetic, both have high blood pressure, and just that puts me at a particular risk. So, watching what I put in my mouth, that's one, and intentionally moving. And as a provider and faculty, those are kind of sedentary, unless you're in the ED moving around for 12 hours.
Right.
Those are sedentary occupations. Those
Mhm.
are occupations, couch potato occupations. I'm sorry, guys, I put it out there. So you gotta, the gym membership may not work financially for my folks, and at one point it didn't work for me because I couldn't afford it. Let's keep it real. But I walked. Um, I didn't live in the best of the neighborhood. So you think about how those social determinants where you live affects even the amount of exercise you can engage in. Because if your neighborhood is not safe, who's going to get up at 6 o'clock in the morning to go for a walk when you have to fit it in? So it's about parking the car, walking the 3 blocks, taking the train, getting off. That's what I do, getting off at 86th Street when I need to be on 70th. Planning these activities and making them a part of your routine. It's about not picking that huge plate. And these are things that I tell my clients. Don't go for the big dinner plate at dinner time. Holidays are the hardest. Take a small plate, a small dish, and don't pile up, pile across. And let's look at my food plate, and that's a tool that that I commonly use, and that's how I live my life. I went from almost 315 pounds to I would say I'm a good 179. I did have COVID, and so COVID was caused me to lose about 10 pounds. I'm not where I used to be, but I'm healthy, and it didn't happen overnight. This is like a 6-year journey. So, and you have to be intentional. And as someone says, I think it was Dr. Vital, correct me if I'm wrong, you have to role model. You can't be the nurse smoking the 6 packs of cigarettes coming into the room, smelling like a chimney, and think no one notices. And on discharge, say, "Here, you interested in smoking cessation? Or
Right.
here, you probably need a cigarette, a patch. Let's start at the highest level to bring it down." And they don't take you seriously,
Right.
right? So it's about that. It's about role modeling, being that role model, whether it's in the clinic with patients, on the hospital unit with patients,
Right.
or in the simulated clinical experience
Experience.
that
Yeah.
happens daily, which is our classrooms.
I think it's also important. So, and I love the fact that as nurses, we're using ourselves as role models. I love the fact that you're all talking about the importance of your cultures and making sure that we continue the education for healthcare providers as because it's so important, as you all shared, that initial conversation with your patients, because it's going to be the sticking point, whether they stay with you or not, and if they're successful. right? So it's just managing. There's a lot to manage, but I love listening to the involvement of how we're managing patients. I'm going to jump to the next question, and it's about obesity as a disease and a complex disease, especially as we look at women. We have hormonal and metabolic changes creating different challenges at different stages in a woman's life. Do you see, or do you manage your female patients differently than male patients? Dr. Orestal, do you manage female patients differently than your male
I
patients?
mean, as I think in the opening, it was said that obesity, the approach to obesity management is not a one size fit all. It's
Never.
also not a one gender fit all.
Mhm.
So I manage my obese persons, right? Differently, and it is not male versus female, because we live in a world now that we have to be sensitive about these conversations
Correct.
and even the words that we use.
Right.
It's looking at the individual and really seeing where they're at, right? Because hormones play a role. I may have a obese 55-year-old or overweight 55-year-old woman, or what I see a lot these days are women who are in their late 40s and have this idea of what they want to look like now. And they want to lose this weight really fast. And I have to have the conversation like hormonally, your body's changing. You don't lose weight the way that you were when you were 20. You stop, you restricted your appetite, and you were losing 3 to 5 pounds a week.
Right.
We have the conversations it's a different conversation. You can't approach obesity in a one gender manner or one size fit all, right?
Right.
It's based on a case by case. Some people need just diet and exercise. Some people need behavioral interventions. And it's not about pills, and it's not about exercise. It's about changing behaviors. And that's a huge component to managing obesity. And we haven't even talked about morbid obesity, because that there requires surgical interventions,
Right.
and it requires before you even get to the point of surgery, the many different components, the psychological support, the nutritional support, the medical support in forms of the different specialties. The cardiologist has to sign off, the pulmonologist, etc. So we want to prevent our clients from getting there. And
Hmm.
it can happen really fast, because you put on 5 to 7 pounds a year because you're not mindful of the lifestyle
Right.
and the choices, which some people, based on their socioeconomic status, they have no choice, because the bodegas, they don't have the fresh fruit.
Right.
Every corner is a Chinese or fast food restaurant that's cheap and fast.
Fast. Right.
So it's really teaching them about the behaviors and what are the alternatives. What are some of the alternatives? You can have French fries, but how about only having 10 French fries as
Small.
opposed
A
to
small package, right? Instead of that large or
right?
extra large. Yeah.
You can't tell my people they can't do something, because they'll take the medication, because we're using metformin now to glucophage to help with weight loss. They'll
Okay.
take the glucophage, but in their head, I'm taking this med now. Now I can do I can eat
Whatever I
this
want.
way.
Hmm. And Doctors Vitale and Doctors Lee, what are you seeing that it is working in your organizations in regards to obesity management? And if there's anything that you're doing differently for male versus female?
So I'll go next, Dr. Patel, if that's okay.
Sure.
So I guess because of my educational background, I always look at data. And really based on the CDC, I don't think there's really a significant difference between obesity rates in males and females. However, when we get to severe obesity, that's when there is a significant difference between males and females. And of course, when we get to talking about race or ethnicity, I think Dr. Patel mentioned earlier about the Hispanic population, but literature, I mean, there's robust literature to show that the group that's most affected by obesity are African Americans or Black females. So when I'm in academia now, but when I was in practice, and what we teach our students is the first thing we want to do is destigmatize the disease, the chronic condition. We want to let the person know, first of all, that yes, you do probably need to change your diet. You need to increase your exercise according to the national guidelines. But those are the risk factors that you can control. Here are some risk factors that you cannot control. So because you have, let's just say, 3 risk factors that you cannot control, the 2 that you can control, those are the 2 that we want to target. So we start off with realistic expectations, sort of like what Dr. Orstall mentioned. So for example, if we're talking about exercise, okay, maybe you can't get the 30 minutes in, but if you're watching television in between your TV show, in between your shows, when the commercial comes on, can you get up and walk in place the entire length of the time that the commercial is on? Small steps, okay? Thinking about things such as, like Dr. Orstall mentioned, don't get the big plate, but also thinking about, okay, maybe a portion is, really what I can hold in my hand, as opposed to, because you go to the restaurant and they fill your plate, it does not mean you have to eat everything on your plate. So other practical steps, such as we all like to eat out. So if they fill your plate, asking for a second plate and taking some of the food off of that first plate and putting it on the second plate and maybe pushing it to the side or acting as if it's not there. Just practical things. And then we also do, if there is a need, we do talk to patients about pharmacology therapy, because that is the continuum of care in terms of treating obesity. We want behavioral modification. We want pharmacology therapy if necessary, and then surgical intervention would be our last step. The issue with the pharmacology or pharmacological therapy is that it's just not widely accepted that anti-obesity medication should be a part of the continuum of care. So that's some things that we need to change. And we're working to do that through our organization, the Nurses Obesity Network, in terms of getting anti-obesity meds to just be thought of as a diabetes medication.
That's great.
So that it will be covered by all insurance companies. And if I could just say one other thing.
Of course.
Most providers, or I'm sorry, most insurance companies on your job, and they give financial incentives if you enroll in a wellness program, okay? But they don't give that same incentive, so to speak, if you try to address your obesity through pharmacology, lifestyle modification, or whatever, which in terms will reduce the insurance company's cost long term, because it's going to be associated with chronic conditions on down the road.
Thank you so much. Such important information. And I love the fact that, again, the Alliance is working on making that medication, that's part of the continuum of care and should be available for all. Dr. Vital, would you like to add anything?
Sure. So as my colleagues mentioned, there's no cookie cutter approach or one size fits all for the care of obesity. And one thing for the Hispanic nurses, it's really important for us to advocate on behalf of our Latino culture and to help educate our our healthcare providers, to make sure that they understand that there are various subcultures within the Latino culture, such as Mexican, Puerto Ricans, Cubans, Dominicans. And so it's important to take that into consideration as well, and the various regions that our communities are coming from, because there's going to be some various challenges and needs, those barriers to providing obesity management. So it's really important for us to take that into consideration. So this way we can develop those culturally appropriate, culturally tailored interventions essential for advancing the health of our communities. And yes, again, just the differences within the subcultures that are out there. So taking that into consideration as well.
No, it's so important. And so my last question before we take a couple from the audience is, how can we provide some advice to the women that are listening today to make sure that they are getting the best treatment and being provided the options for treating obesity? Dr. Orestal, I'll start with you. How can we make sure, like, is there certain questions, like how can we make sure when that patient is in front of their healthcare professional that they are getting the best treatment and being provided the best options for them?
So part of it is the awareness, doing things in the community, in our different community-based organization to heighten awareness and really teach clients what they should be asking their doctors, their providers. I always tell my folks when I see them, 3 questions, right? What 3 questions do you have for me, today as we end? And part of the factor with being chronically ill with obesity is the stigma and the shame, because as an obese woman, formerly obese woman, and it's not, I mean, I'm just, a couple of thousand of calories a day away from going back to my past self. It's about not being embarrassed, because any provider you go to, they have the professional responsibility to tell you that you are at risk and that your BMI is high, or you're putting yourself at risk for this or that. But the rest remains on you to have that to say as the patient. Okay, doc, or nurse, what can I do? Don't be afraid, don't be ashamed, because I was, I attribute my weight, my being overweight and obese for the majority of my life, to it being okay, familial, in my culture. But when I got to the real world, when I remember one time, and this is shame on this provider, I got my first nursing job. And I went to employee health. And at that time, they actually this is like 20 plus years ago, but they actually put their hands on you to examine you. And I remember the doctor said, wow, sheesh, you got to do something about this stomach. And I was like so ashamed, like I felt so bad. And so it came to the point that when I went to my own provider, I didn't want to get on the scale. I would tell them, you don't have to weigh me. This is my weight. Write this down. So it's really about, telling people it's okay. It's okay to have these questions. It's okay to ask, what can I do about my weight? I'm doing the diet and exercise that you told me to do 3 months ago, but it's not working. And for some reason, because of other things, thyroid disorders, metabolic issues, it may not work. Again, not that cookie cutter approach, but it's okay to ask the question. And if you don't ask and make that conversation pivotal to you, just like, if you, like for me, I have a fear of flying. So before I fly, I go and make an appointment with my provider, who's a nurse
Mhm.
practitioner, and I'll say, "You got to help me because Benadryl doesn't work anymore." Um, and so I made it intentional. So you have to, don't be afraid. Don't be afraid. It is your right. Just like you're being treated for high blood pressure and
Mhm.
diabetes, you need treatment for obesity, as Dr. Lee so eloquently put in her response.
I love it. Thank you. And I'll jump over Dr. Lee. Any additional input on
Yeah.
how can we make sure our patients are getting the best treatment plan?
Just quickly, I would echo what Dr. Orstall said, to ask your provider just simple questions such as, what are my options? Does my weight, or is my weight contributing to my chronic condition? Say if you're there for diabetes or hypertension. If you're a nurse, I would encourage you to utilize the National Black Nurses Association website. We have a robust discussion about obesity on the website. We also bring attention to Obesity Cure Week. So make sure that you are informed before you go to see your provider, and know that you don't have to be uncomfortable, because the person coming into the doctor's office behind you probably has an obesity issue as well, or they're dealing with the obesity epidemic. It's very common in our society.
And Dr. Vitale, anything else to add?
Yes, and just to echo what my colleagues have already said, empowering our patients, making sure that they're empowered to.
I couldn't agree more. And now we're going to go to some questions from our audience. So Donna asked, access to care is really critical, and the cost to access to care can be insurmountable obstacle, even for those of us who are lucky enough to have insurance. Great innovations are being made in obesity treatment, but they are useless if treatments are not covered by insurance or are so expensive that patients cannot pay out of pocket. Are there any advocates or agencies that can help us find affordable care? And I know, Dr. Lee, you talked a little bit about the great work that all of your organizations are doing collectively, but does anyone want to answer that question?
So I'll speak to that. I agree with what you're saying. I can't tell you that off the top of my head I know of any organizations that can help you, for example, pay for ALMs, or anti-obesity medications. I can tell you that through organizations such as the National Black Nurses Association, the Nurses Obesity Network, that we are targeting our legislators in DC, or congressmen and women, to get them to really look at policies and making changes to policies so that these medications or behavioral therapy is usually covered, but these medications can be covered. The military, people in the military, they generally don't have this problem because ALMs are covered for their group. And I believe in 2023, is going to be covered for federal employees. Don't quote me on that, but I think I'm pretty much sure. So I think lobbying and making sure that we try and get our commercial insurances to mirror the insurance of those who represent us, which would include paying for AOMs or anti-obesity medications, would be great.
I think so too. It sounds like access, affordability, a good, strong policy issue. Next question is from Donica Moore. Can you go into a little bit more detail about A1C and its significance, and who should be tested for this? Who wants to take that question?
I'll hop on then if you don't mind.
Go ahead,
So,
Dr.
it used to be that the A1C was a modality to highlight and really put out there those who are at risk for diabetes, have prediabetes, are diabetic. So we look at the A1C now, yes, as a diagnostic tool, but also how well one's blood sugar is being managed. We also look at your chem stick or your blood glucose levels as well, and that is a wonderful way of seeing someone's risk, right? A random glucose
Right.
test or a fasting blood glucose.
Right.
I think what's really important to note is that anyone that I see in practice, even when I lecture with to my students in regards to this topic, it's important to know that we screen. I screen everybody, right? All the adults that I come into contact with, and it should be part of your health screening. Just like you go to the doctor, and once a year, if you're healthy, you have to get A, B, C, D, and E done as part of that. Um, Chemistry profile of your
Right.
labs, you need to know those numbers. And again, it's about asking those questions. That's not hidden from you. Just like you need to know what your weight is, you need to know what your cholesterol level is, what your blood pressure is. You want to know what your glucose level is. You want to know what your A1C is. And those things are really significant, and it's important to have those conversations.
So engage, empower, and educate. Those are the three takeaways that I'm grabbing from our wonderful conversation. And I have so many more questions that I would love to throw out there, but I know I'm taking so much of your time today. We're over. Such a great conversation. I love talking to all my nurses. Thank you so much for joining me today on this episode of Women Talk. And for our audience, please join us again for our next episode of Women Talk. Thank you very much, and have a great afternoon.
Thanks for joining us for another episode of Women Talk. Stay tuned for more Healthy Women live events at www.healthywomen.org. You can also follow us at Healthy Women on Facebook, Twitter, YouTube, or LinkedIn, or follow us on Instagram at HealthyWomen.org. We'll see you next time.